Next up, we have Dr. Brendan Gallagher. Dr. Gallagher is a board-certified pediatric anesthesiologist with specialized training in the perioperative care of infants and children. He earned his medical degree from LECOM and completed both of his anesthesiology residency and fellowship at Penn State. Dr. Gallagher is passionate about delivering safe and compassionate care to the youngest patients and supporting families through surgical experiences. Outside of medicine, he enjoys barbecues, tiki cocktails, that's very nice, and spending time with his wife, their 2 children, and the family's 2 dogs. He will be speaking on rethinking NPO guidelines and the clear liquid guidelines in pediatric care. Please join me in welcoming Dr. Gallagher.
Hi, everyone. Yes, I'm Brendan Gallaher. I got in touch with Sean through a mutual friend about potentially doing this, and right around that time, my division chair from my department had just sort of completed her work with a Society of Pediatric Anesthesia Task Force that was evaluating potential changes or recommendations for pediatric NPO times. And so sort of the timing of everything, this felt like a relevant topic to talk about. I also have no disclosures, but I didn't know if I should include that I did use artificial intelligence for some elements of presentation creation, including my introduction, so God bless it. So learning objectives, we will discuss the current ASA guidelines that last came out in 2023. We'll identify the common challenges and pitfalls associated with prolonged NPO times in children and why we care about this. Evaluate the safety implications of potentially changing these NPO times and what patient populations this may be a bad idea for. We'll look at what our international colleagues are doing around clear liquid prior to surgery, and then ultimately look at the role of new technology and institutional policy and even considering any of these changes. Our outline will pretty much follow the same order. So, 2023 was the last time the American Society for Anesthesiologists put out large changes for practice guidelines for preoperative fasting from the prior 2017 numbers. The notable inclusions, if you remember from that time, were ingestion of carbohydrate-containing clear liquids, what to do about chewing gum, and the first time they tackled specifically looking at pediatric fasting duration. At that time, no decision was made to make any changes to clears for pediatric patients, but they did make the specific point that you should strive for clear liquid intake as close to the 2-hour mark as possible while not making any official recommendation to change to 1 hour. When looking at the 12 or so studies that they consulted for making these changes, they looked at both the good and the bad that would come with this. And ultimately, they found that the strength of evidence was universally low. So while vomiting, aspiration, regurgitation, and all those things were not particularly riskier when you went from 1 hour to 2 hours to 1 hour, they also found that patient-related hunger, thirst, and nausea, familial satisfaction, for the most part, kind of broke even. So armed with that information, they made the decision to sort of just keep things where they were. So that was February of 2023. Several months later, in the Journal of Pediatric Anesthesia, they sort of addressed this topic, and they made a review of fasting guidelines, both here and internationally, and sort of weighed in on it as well. I think one of the big issues that they sort of talk about is that for a lot of children, children's hospitals are not nearby, and there's sort of excessive travel times that need to be considered. They also found that while they say we should strive for as close to 2 hours as possible, many children are fasted excessively. Times for up to 23 hours have been reported. There's communication issues, surgical delays, and parental confusion and noncompliance, and all of those factors go in to potential issues. I think it's important that we appreciate the nutritional needs of pediatric patients versus the adult population. They metabolize nutrients at a higher rate. They're more sensitive to alterations in their nutrients. Signs of ketoacidosis, metabolic acidosis, hemodynamic instability, and hypovolemia. All these factors also go into the standard induction for most of these patients, where they're mast-induced without IV access. And that hypovolemia and all those other things are exacerbated in that picture. Also signs of insulin resistance from the prolonged fasting prior to these procedures. It's also, when you look at post-surgical surveys of families and parents, the biggest things that went into dissatisfaction with OR experience are post-operative pain and child hunger and prolonged fasting times. As we were talking about earlier, these times often get significantly overestimated, and it's usually much farther from 2 hours by the time these children finally get their procedures and are able to eat post-operatively. It's also important, though, to acknowledge that while these changes are being considered for some, they're not universally considered to be a good idea for all patients. It's widely considered that even in institutions that are making these changes, patients with known GI disorders, diabetes, emergencies, and traumas, it's probably safe to leave things where they are. The other part that gets unclear is some institutions set specific limits around 2 to 3 mLs per kilo, while others allow for a more liberal administration of fluid prior to their procedure. So next gets to sort of where my sort of tie into all this became. So that was 2023, where all that was being addressed. Around that time, the Society of Pediatric Anesthesia created a task force that polled and looked at 75 leaders of various pediatric anesthesia departments around the country to evaluate what they're doing and what their concerns and considerations are around this issue. So they managed to do this through a survey that had, I think, around a 90% response rate looking at all these other institutions. The big takeaways from the survey found that despite the fact that there was no national change suggested by the ASA, about 10% of programs throughout the country had changed to 1-hour times, and about 10% stated that they were currently in the process of changing from a 2-hour to a 1-hour for clears. So currently about 1/5 of children's hospitals in the US are doing this. While important to acknowledge that about 70% found and identified that they think it would be beneficial to make the change, and only 10% stating no, that they don't think it would be of benefit. And about that same number said that even though they think it's a benefit, they have significant concerns about the medical legal implications of changing NPO times without any kind of specific guidance or approval from any national governing body. This here just sort of looks at what was identified as the major issues people were concerned about, or the major motivators for making these changes, including family satisfaction, less dehydration and hypovolemia, decreasing delays, IV success rates, amongst other things. This we sort of already discussed, but concerns about, again, any kind of lack of official endorsement while they were transitioning to make these changes. And there is obviously concern about patient safety and worrying about aspiration risk, despite the fact that the evidence suggesting otherwise. It's important to look back to where we came in the 70s is when we first started the Nothing at Midnight, and then over the last 30, 40 years have sort of changed and liberalized for pediatric patients, the differences with clear fluid and breast milk and formula and all those things. I think it's also important to look at sort of other historical moments that have sort of happened that have complicated fluid administration and resuscitation needs in the operating room. We've obviously all experienced these, the most recent coming from Hurricane Helene in late 2024 and early 2025, and the sort of national fluid shortages that were all associated and a part of that. Internationally, a number of societies across Europe and England have made the transition in 2018 to 1 hour. So Great Britain, Ireland, the European Society for Pediatric Anesthesia, the French Society that I cannot pronounce, and the Canadian Society all agreed to make a change to a 1 hour NPO time, and have, for the most part, been doing that without issue. I think it's important to note, though, despite all these things, a lot of our field, be it regional IV access, these considerations, ultrasound will make massive changes in our ability to do this. This is all sort of based around the fact of wanting to avoid aspiration and other concerns based on something we can't see. Ultrasound is changing that. and the ability to assess gastric volumes and make considerations. Because even in our best efforts, right, we've all had patients where we've done everything right and aspiration still occurs for other variables outside of our control. But ultimately, what do all sides agreed on? Be it 2 hours or 1 hour, it's very important to communicate with families the need for fluid administration and avoiding dehydration in our pediatric patients, as most families will unfortunately overestimate NPO times for fear of surgical cancellation, and ensuring the surgery teams and anesthesia teams are relaying a consistent message. Perfect. And thank you.